This afternoon, I'm privileged to introduce Dr. Srinivasan Krishnamurthy, a member of our Department of Obstetrics and Gynecology, a clinician and a teacher at our teaching hospitals, and, most importantly today, one of the 8 laureates chosen in 2023 as a member of the Academy of Exemplary Physicians. So, Krish, welcome.
Thank you, Professor.
And thank you for joining us to share your ideas and thoughts about yourself as an exemplary physician. So perhaps the best way to start is for you to tell us a little bit about what brought you to McGill. What was your background, your training, and how, of all places in the world, did you end up here working with us and now being one of our privileged laureates? So please let us know.
Thank you, Dean Fuks. It's a pleasure to be here. I am originally from India, and when I graduated from medicine in India, I applied for post-graduation and was unable to secure a position in the so-called residency or MD program that exists there due to various political issues that was existing at that time. So I traveled to England to achieve my goal. So I started working as a junior doctor and got trained fully in OBGYN and continued working there. At the time that I was going to go back to India, I had the opportunity to get further training in the UK. So I continued, and then eventually I landed up with a consultant position. My professors, they there were very much in favor of me continuing an academic career, but I chose to go to a community hospital to work because I did some training there and I really liked the atmosphere and the people. So I went there as a consultant and I stayed there for 7 years. So like all things, you are what you are, and your aspiration to teach still were there with me at that time. And I got bored after a certain period of time. I was there for 7 years. And then I had the opportunity to meet with Dr. S.L. Tan, who I met in a meeting in Sweden where I was presenting. He came to me and asked whether I would be interested in joining McGill. So with no thought, I actually applied because I know what it is to be in a teaching hospital and to be surrounded by the atmosphere and stimulation. So I did apply, and if I remember correctly, it was you who were the dean at that time and who appointed me. So the main idea for me to move to Montreal, and in April I came to look around and it snowed at that time. Despite that, I chose to come back to McGill, and it was the big names that were there. It was Dr. Togas Talandi, who's published widely, and S.L. Tan, who was in a academic career that was really very well known at that time. So I chose to come, and I haven't looked back ever. So it has been fulfilling, flourishing career at McGill. So I'm glad to be here.
Yeah, we're glad you're here for sure. It's interesting you mentioned that when you were doing clinical work alone in a small hospital, you were bored. What were you looking for? What were the added elements that weren't there?
So we did have some students and some registrars who are the trainees in England. But it was the atmosphere was not the same being in a teaching hospital. It's surrounded by trainees and residents, registrars, and equally your colleagues who are much more motivated. And it's a stimulation that you get from these people. And you want to be ahead of your trainees. You need to have the knowledge, so you keep yourself abreast of all the developments that are made in clinical and research areas.
So the teaching hospital gives you not only a chance to teach, but you're implying that it also makes you a better clinician for your patients.
I'm pretty certain that's, if you want to, I was still the same person there, and I learned all the way along. But it's just that missing of that little bit, that the stimulation that you have in the teaching hospital. And I think I learned all the way along there when I was young, and you're hot-blooded and you're different than when I am now. I'm able to control my emotions and to be able to deal with patients' anger, happiness, sadness, and everything better.
Right. Were there role models back in India that were an inspiration for you to choose obstetrics and gynecology as a career path?
It was the patients that made me choose. I'll give you an example. Please. I was a intern, so in my teaching hospital, and I was actually manning the emergency area. So the patients come through, and you're the intern, you're the first contact, and you choose what you did to the patient. So there's a woman who walked in who's 40 years old, who was pregnant for the 9th time, and she has 8 children already. She was laboring in her village, and she was transferred because she was not making any progress. When she arrived, and I examined her belly and examined her vaginally, and then I made a diagnosis of a ruptured uterus. And this patient was treated in the local center, and she was given oxytocin, and she didn't progress. She was given oxytocin because she didn't progress, and then she was transferred here. So it was a question that I asked the patient. I said, you have 8 children. What made you choose to become pregnant again? And she said, I have 8 girls. I wanted a boy. And we delivered this dead baby boy from her belly. So that was a very sad moment. And I thought this lack of education that made. And another instance was the critical thing that made me choose to do obstetrics was when I was in the same delivery room, a young girl who was 17 years old, who was pregnant out of wedlock. So that is not considered anything sacred in India at that time. And this patient had severe preeclampsia and became eclamptic in labor room. And the senior doctor who was there at night told us, because we were like interns that were there, like 14 of us, I was looking after her and my colleague, and she said, let her be, and I think she's really not going to do well. Don't give her anything, just leave her alone. And she was meaning that just leave her to die. So the 2 of us were very vigorous, and we said, we can't let this girl die. So we read the books, and we gave her the treatment. In the morning, she delivered a dead baby, and she was alive. And the person who came, the senior doctor who came, and was very surprised and was really quite angry with us. And that made me very sad. So that made me choose obstetrics and gynecology.
These are quite amazing narratives, because in both instances, there were very sad stories and resulted in babies who were no longer not viable. And yet that somehow motivated you to say, this is what I'm going to do. These very are quite true. Remarkable. So it's intriguing that these 2 sad stories were an incentive to choose a specialty. Can you remember other narratives, other stories of patients that stayed with you, whether they're sad or happy, but they're memorable for you as a caregiver, as a clinician? Can you share any special ones with us?
Yes, there are very many. Because at that time in India, abortions were legalized already, but many of the patients did not know. So we used to get patients who will have backstreet abortions in their villages. So usually the traditional birth attendants will try to terminate the pregnancy with the caustic sticks through the cervix into the uterine cavity. So that will result in significant pelvic infection. And they became, and they were treated, but because of the lack of antibiotics, consistently available antibiotics, the patients will continue with really indolent infections for over a period of time, and they'll be admitted with chronic renal failure and severe pelvic pain in the gynecology wards. So we used to look after all these patients. It was like very sad. And this made me motivated that we need to educate women. We need to give more power, empower them to look after themselves. So that was the main reason one of the main reasons why I went into gynecology.
So tell me, when you learned that you were chosen as one of the laureates, this is, as you know, the first group of individuals that were honored. There's only 8 from all our wonderful clinicians. What was your reaction? What occurred to you when you learned that?
To some extent, it was a surprise because I didn't think that I was anything exemplary personally, and I think I was an average clinician, and I've seen many very, very significant clinicians amongst my faculty in the Department of OBGYN, as well as in other departments as well. So it was a bit of a surprise for me, but I was very, very pleased that I could relish the moment and be part of the group that you invited us to receive the award. And it was a moment that was very, very, I felt that I achieved something for coming after the 23 years I've been in Montreal. I feel that it has been worth it to be here.
Yes. In what way would you characterize a day of work? What does a day of work look like for you that you can share with our listeners and viewers?
So, for example, yesterday I had a full day of gynecology clinic. So it's preparation. I prepare the day before so that I don't have any surprises. The new patients, I already know why they are coming, and if there's anything else I have to do, so I will like collecting the results and everything, so I'm not looking at the last minute faffing around in the clinic. So that I prepare, and then I'm ready to receive the patients, and I have a trainee with me. So first I introduce the clinic to the trainee, then I go through how it works, the electronic medical records, and I go through why the patient is there and show them I have already prepared the charts that they need to fill in. And I tell them that they take the history and come to me. We discuss, we go back and explain everything before examining the patient and to get their management plan. So that is with the trainee that I do. And that is the most fulfilling part of the day for that day, simply because it's either a medical student or the resident. I tell them what I'm going to tell the patient is what you need to learn. So every patient, when I explain, whether be it infertility or I tell them the rationale, what we are going to be doing, or whether a patient with a prolapsed uterus, so what's the options of management and the physiology behind it. So that is what they need to learn. And so yesterday, for example, I had about 4 patients with prolapse. The medical student told me, I've seen 3 prolapses today, and I don't need to go and read about it in my books. So it was really quite good to hear from the student that I have made a difference to her education in that way.
To her learning.
So it's to prepare and be ready. And so there were patients who were upset for some reason, and to be able to comfort them and to be able to guide them properly. And so those are all the parts of the clinical work that you do.
Right.
So educating the patients itself is the biggest thing that I can do every day practice. And that forms the basis of educating the students. Although reading from books and so on, when you apply to individual patients, they see that how it is done.
Right.
And that makes a difference to the education.
It's interesting that you see a connection between these two forms of education, educating the trainee and educating the patient. How do you see them connected? What makes you put them together in the same sentence?
So to the patient, you are going to do, the education is going to be in the lay language that they can understand. So when I finish, at the end of my conversation with the patient, I turn to the student and I can tell them, do you understand? Do I need to do it any differently for you? Then most of the students will tell you, no, we understood. And I always tell them the day when we do the orientation, we tell them, when you come to the clinic, please read about these conditions that you're going to see. So they already should be prepared. Most of them are. And when they come, they tell you, yes, I understood now in simple terms how it works. So it's literally the same thing that you need to do for both of them. Yeah.
So it's the same actions, in effect.
Exactly.
And the two are connected.
Yeah.
What I mean, you're in a specialty, like most specialties. There are good days and there are bad days. That's unavoidable. So when you come home and say, I've had a good day today, what does that mean for you? What does it look like and feel like?
I'm able to talk in the first place. When it's really a bad day, it's either bad days are not necessarily bad outcome days.
Right.
It's because you've been doing far too many things and you had no rest in between. So when you come home, you are able to relax and to be able to think back and say, did I do anything that wasn't that shouldn't have been done today? Right. That's something always comes to your head. And I was thinking yesterday's clinic, I said, did I finish these things I'm supposed to do? And I'm always going and checking in the electronic medical records. But it's the bad days, real bad days, or whether it's bad outcome, and then you come, you reflect on what you could have done. Sometimes you know that there isn't anything that you could have done that would have made a difference. And for you to know and that you did your best and this was the situation that was meant to be that way. And that is something very hard as a patient, it's very hard for them because they think it's somebody. Is it my fault? Is it the doctor's fault? Is it environment's fault? We always look for some answers.
Sure.
And for some reason, when you're older, you just think there isn't anything that you would have done that is going to have made a difference.
Right.
So that is the difference that you need to be aware when you come home.
Right. So when you do come home, it sounds like you don't leave the clinic behind. You're kind of reflecting on what happened today that was good or could have been better. And that forms part of the end of the day for you.
Yes. Without completion of works and that is pending, it's not going to be, you're not going to be able to put your mind to rest. It doesn't take very long, to be truthful. I am home. Once you have your dinner, after that it takes about an hour of work just to ensure that you've done everything that you should have done. Because sometimes you leave the clinic because you have something else to do and you haven't dealt with, you tie up the loose ends, and it takes a little time. And also another half hour for preparing the next day. So after that you can relax.
So you prepare for each clinic the day before?
Yes, I do, because that has become part and parcel of my routine now. Because otherwise, when you are there and you are trying to find the results, you're trying to find the referral and all those things, it makes it longer for the patients in front of you or waiting in the waiting room.
Right.
So if you're prepared, and it takes about 30 minutes, 45 minutes for a full day clinic. I mean, you don't have clinic every single day.
Right.
We have a clinic like 2 days a week or the maximum 2.5 days. So from that point of view, it doesn't take very long. Because I think as a physician, your job is not always 9 to 5 or 8 to 4.
Right.
It's much more than that. And I think it may be that it's a generational thing too, because we were taught in a different way than the current generation. So there is a difference in our upbringing as well.
So tell me a little bit more about that. What are the differences you see that are kind of intergenerational differences, whether students are different or staff are different or maybe patients are different? What do you think?
They're all different, to be truthful. I think in a sense, but start from the students, that would be a very good place to start. And I think students, when they apply to medicine, they are very rigorous and they have good competition and they enter in. And once they are in, it's a bit surprising to me to some extent because you made all this effort and I would think that you will be looking forward to every day doing things. But what is the main difference is in the past when I trained, it was very, very different. So you were told to do something and there's no questions. You went on and did it.
Right.
Now it's very different because their way of thinking is different. That's I need to look after myself and I need to ensure that my health is good.
Sure.
And all those things these are very important, which we probably ignored as students and young people, as young staff. Whereas now it's much more to some extent, it's surprising to us. And, think, what is this? Why can't you do it when you have the opportunity? So it's very important to learn that it's us we need to change and not them.
Right.
So that is very difficult. For people like in my generation, it is very difficult to come to terms with it.
Right.
But I think slowly we are. Second, about the patients. So the patients' expectations are extremely very different. And they also are exposed. They have more knowledge. Because of the internet, they have a lot of knowledge. Whether it's good or bad, they will come and challenge you. And you need to be prepared. It is not anything bad. In fact, it's good in a way that they are educating themselves. So if you're not prepared to post this challenge, to look into it, you can be disappointed, you may get angry, you can be not as good a physician as you can be. But you need to be open and you need to be able to really answer their questions and their challenges, because it's okay not to know certain things, and you can always tell them that I don't know, I'll look into it and let you know. So that's something, because that's also a new generation. So they have a lot more questions. So I can think of doing an obstetric clinic 15, 20 years ago when I could see like many patients in a day, because there are not many questions asked and you just did your routine. Now I did this morning a clinic which each patient took me about 20 to 30 minutes. If they have first pregnancy, they have a lot of questions, and we go through a lot of items in their list of questions we go through. It is a lot different. Third is the young colleagues. Young colleagues are just new ones who just joined the faculty, and they have just been residents. As a resident, they have a pre-call time off and then the post-call time off. So that when they come in from residency and they join faculty, they think it's still the same, and so they want at least a post-call time off. And we look at it, and I think probably it is better because these people have worked hard, and they work very hard during the time that they are. And I can go back and remember that I started my call on a Friday evening after finishing the all-off Friday.
Right.
And then I did a call Friday, Saturday, Sunday, and do my regular shift on Monday, go home Monday evening.
Wow.
So that doesn't happen anymore.
Right.
And it's better that it doesn't happen anymore.
Right. It's better for patients as well.
Exactly.
I'm sure.
Yes. Yeah.
If you were trying to convey some of the things you've learned, not in medical school, but as a clinician over many years in practice, what are the concepts that you've learned that made you the clinician you are, that you think you want to teach or want to demonstrate to the next generation? What are the ideas that you feel most important or most urgent should be taught to the generations coming in now?
The first and foremost, what was said in the past, so knowledge is power.
Yeah.
That's a main thing for them to remember. All the soft skills you may not know initially, you will learn over a period of time.
Okay.
So the dictum that what the mind does not know, the eyes do not see. That is the key thing to remember.
Right.
So unless you know what you're looking for, you're not going to find it.
Right.
So knowledge is going to be very, very important for people to acquire. And that comes with hard work and looking into various aspects and learning from each other. Mm-hmm. That is first thing that I would impress upon all the students, residents, and young colleagues. Second, humanity. So with the patient in front of you, that is, there will be a lot of emotions that will come. Okay? That is something that you need to learn, to the cues that you get that will guide you in the way that you manage them. That's going to be another important thing. And I think it comes with practice over a period of time. And many of us are very aware of it and some not very so. So therefore, that's something that you need to
It's important.
To learn as well, or to be aware of. And third thing is to listen to patients very carefully and pay attention to details. That is very, very important when you are going to make a plan of management. That is going to be crucial. So listening to the patient and paying attention to details. And the last thing would be in terms of managing a condition or a situation is you give them choices and let them choose. And unfortunately, sometimes the choice may not be right. But if they are comfortable with the choice, you explain to them, this may not be the best choice for you. But if they are comfortable, and they will come back and tell you, I didn't listen to you, I should have done what you told me to. So that actually, at that time, you say, that's not a problem, we're going to do the next step. And you still have a choice. Because there are patients, even with cancer, who do not want the treatment that you suggest to them. And you need to be able to listen to them and to guide them and to be supportive of what they want to do.
Right. Maybe we can go back to a couple of your interesting comments. When you talked about the importance of emotions, do you mean the patient's or your own? Which emotions are you talking about?
Both.
Okay.
To patients' emotions are important, that you can't control their emotions. And so you need to listen to them without getting angry or without getting sad as well. But equally, your emotions, because you are also a human being, you have the same emotions that they have. And it's important for us not to you need to control your emotions, and you should know that you are there to support them. And it's not about you, it's about them.
Okay.
So I think it's this unfortunately comes with time and experience. Some of us are gifted, and as a young person you'll be able to. Some of us learn over a period of time.
Right.
And sometimes our encounters is not very good with each other, and at that time you need to think, okay, so there was a student, for example, there was a student with me, and I had this interaction with the patient, and I knew that it didn't go very well. Okay, so at the end, after that, I apologized to the patient, and then we dealt with it. Then she left, and then I spoke. The student was there, and I said to him, as I didn't do that very well, did I? And the student said, well, I thought it was, the first bit was a bit rough, and it was like a little bit of interaction that was not very good. But I was really astounded that you actually apologized and you said that I'm wrong in dealing with you. So I think that is the bit that I learned, that you should be able to acknowledge that you are wrong and to be able to deal with the problem as well.
So the student said that he learned from watching you do that.
Yes.
And I guess you mentioned that those kinds of skills, that you call them soft skills, and many people use that phrase, but those are acquired obviously through experience, right? Through many patients and many years. Yeah. The other comment you had, which all good clinicians talk about, is listening. So we all think listening is, well, you have a microphone, somebody's listening, but you mean a different kind of listening. What are you talking about that makes the clinical acts different and deeper?
So it is the free time that the patient can express themselves.
Right.
So when you ask them the open-ended questions and say, what's the problem that brought you here? And without interrupting, let them tell the story, why they are there. And listening to them, it takes time. And when you have less allocated time per patient, you think that it's not a good thing, that we need to direct them and to get the information, which will be okay in certain circumstances. But it's not going to be in complex situations. In most patients, when they come, there are not a lot of things that they are going to tell you. They're going to tell you the real problem that they came with.
Right.
There are some patients who have other issues that go with their problem, and they are trying to tell you, and if you interrupt them, they're not going to. For example, in gynecology, there's a very crucially important is conjugal violence.
Sure.
And that there are cues that are there that you need to pick up and be able to identify and ask them. If you let them talk and freely without any interruption, they're going to really come out with information. If they trust you, they're going to give you that information. So you should be able to listen to all these.
Right. So you're actually sometimes listening for the cues and the clues of conjugal violence, of spousal abuse.
Yeah.
And you learn to recognize it. Is that right, when you listen?
Absolutely. I think it's over a period of years. You just learn again and again. I mean, there are like lots of educational resources that are there which will tell you, but actually listening to them is it's very revealing, and you can go into details of it slowly but steadily.
Right. But you mentioned an important word, Krish. You said that they have to trust you.
Yeah.
Before they'll open up in that way.
Yes. Yeah.
How does that trust get established? What are the means, the behaviors, the language you use? How do you do that?
So first of all, it's breaking the ice with the patient to ask them about themselves. So that makes them interested. First thing is just, it's not official. You just say, why are you here, and start taking history. It's first when you greet and there, and the questions that you ask, what do you do for a living and where do you
Right.
and tell me about your children. All these things matter. So I think getting to know the person as she is and to ask them about their surroundings, and this it takes 2 minutes. You're not going to be dwelling on this for a long time. So it's to ask them, what do you do? And that makes an interesting question. And if she says, I'm a seismologist, so say, oh, wow, that's interesting, and tell me about it. What do you do? I'm an actor. And you ask about them, wherever you acted, anything. So it really opens them up. And so they actually tell you more about themselves. That is just one part of it. And then trying to listen to them and acknowledging them that they have a problem and not to dismiss them. All those things will
Right.
make them interest you. Yeah.
So tell me more about that interesting verbal combination. You have to acknowledge and not dismiss. What are you talking about there when you describe that?
So, for example, sometimes they say pelvic pain, and then you ask questions, and it doesn't fit in with what you expect it to be. And then you say, okay, well, that doesn't sound like, what I think it is. And they say, they'll tell you, I've had this for a long time, and, it's just exactly like this. It comes just before my periods, and it lasts for this long. So say, well, everybody gets period pains. It's not like really that big a problem, and we can treat you simple. Then they think that you are trying to not to believe what they are trying to say. Right. Then you need to establish whether this is really what they coming there, possibility of endometriosis. You need to believe them and to be able to get deeper and what information that you need to gather, as well as whether you need to get the investigations done. That is the reason if you keep dismissing them, the diagnosis for endometriosis on average has been shown to be delayed for 8 to 11 years.
Wow.
In North America. So I think it's because people don't listen and to take things seriously.
Right. Or they jump to conclusions prematurely.
Yeah.
But the important point is that listening isn't simply a form of being polite. It's a form of acknowledging the other person's validity or authenticity. But also, as you just pointed out, it's the only road to make an appropriate assessment and diagnosis.
Exactly.
Is to get the correct information. But this notion of being dismissed is a very powerful one, and certainly has been a very strong theme in feminist studies and theories that women talk about being dismissed and not taken seriously is a very strong statement that you sometimes hear from patients who are not happy. Certainly in obstetrics, there are many patients who are very happy, and the families, and I'm sure you are. And are there relationships that develop between you and a family over time that are important to you?
Yes, it's because that is the beauty of obstetrics and gynecology. You start looking after them as young women from teenage years. They have problems, and you address them and deal with them. And vast majority of them get pregnant. So you've established a relationship. They come to you for the pregnancy and childbirth. And then they come back to you for the care, subsequent care, and until they go into menopause and after. Right. So that is the thing that you establish in obstetrics and gynecology, which used to be more profound in the past than now.
Is it? Okay.
Because of the shift work and the theme of that it's the care is fragmented. So I do only this part of obstetrics and gynecology, this part of this. It has its advantages that you really become an expert in that part of obstetrics and gynecology, but then the patient's continuity of care is not there.
Okay.
Okay, but having said that, you can always establish, even if you are an expert in it, they will actually trustingly will come to you, because at the end, knowledge, being kind, and being an expert in what you do, that makes a big difference, and you can compensate for this continuity of care in a small proportion as well.
Right. So it sounds like for you, the knowledge and expertise is already entangled with what you call the humanity.
Yeah.
That you don't see them as separate in any particular way.
Not at all. I think it's, but having said that, though, I have seen physicians who are extremely good with the hands and knowledge, but they're dealing with the patients is not something to be desired.
Right.
Okay, so that I have seen the kindness and with which that you deal with patients. I think that's a very important part of medicine, and I think that's something which I will, time and time again, I will teach the students and residents. This one example I'll give you. It's where we have early pregnancy rapid access clinic. We established it at the Royal Victoria Hospital. Now, it's been in existence because my training in the UK, that's been there 7 days a week. Patients, women who are in the early pregnancy with bleeding and pain, we see them to establish that their pregnancy is ongoing and is in the uterus. So that is a most distressing part of the time for these women. So they used to go and wait in the emergency room for long hours. The quality of care was very, very poor. So therefore, the hospital, quite rightly, I kept telling them that we should establish this. Eventually, they agreed and they gave the resources. So we do them, and we do these clinics with the residents. And the most important thing there is being kind, and because some of them will come and it's very simple. They are there for ultrasound. You do the ultrasound, show them the baby, and everything is good. They're happy, they leave.
Right.
The times that the women come and the baby is dead or it's not growing and so on, and this is a time where you need to be very kind to these women. It's very distressing, and they are grieving. So that is the time, if you are not kind to them, then it's, you shouldn't actually be a clinician, because I find that it's very crucial that you learn this aspect of medicine, being a human and to be looking after someone at that vulnerable time.
How do you learn that?
I think most of the time I actually look at other people. For me, it came. So I saw a lot of clinicians in the UK when I trained, and I'll see people and say, I don't want to be like this, because you inherently you learn how not to be and how to be. So I learned a lot of people who are very kind and who were dealing with the patients inherently, and I learned for asking to be personable, you need to know about the person in front of you. I learned it from a very senior clinician. I used to be a registrar in Glasgow, and I learned a lot of my colleagues, even my own trainees who were with me. I learned a lot of things that how not to do as well as how to do. So
it's interesting. As a result of that, you can tell us that if you can't be kind to your patients, you shouldn't be a clinician.
More or less, yes.
Yeah, well, it's a strong statement, but I imagine many clinicians are probably going to agree with you, and maybe even many members of our academy, our laureates, might indeed agree with you. So thank you for sharing your wonderful ideas, your concept, and your special stories of the patients that you've met, both the difficult ones and the happy ones. So thank you for being part of this group, and thank you for being part of this interview.
Thank you very much, Dean Fuks. It was a pleasure.
Nice to be with you as well.